What's up, everybody? This is Jeff Moore, currently serving as the CEO of ICE. And before we jump into today's episode, let me take a moment to introduce Jane, the clinic management software and EMR that so many of us in the ICE community use and practice. Change is a normal part of clinic life. Maybe you're expanding your team, introducing new offerings, or growing your client list. As your clinic evolves, it's important to have an EMR that not only supports those changes, but also grows with you. Jane's new Balance, Practice, and Thrive pricing plans offer flexibility, allowing you to easily switch from one plan to another depending on your current and future needs. There's no long-term commitment either, just simple month-to-month payments that let you focus on running your clinic. And with every plan, you get features like one-on-one telehealth, email appointment reminders, and unlimited support. Visit jane.app/pricing to find a plan that fits your needs starting at $39 a month here in the US. And when you're ready to get started, use the code ICEPT1MO to sign up for a 1-month grace period on your new account. Thank you so much and enjoy the show. Paul, what's up, man? Good to have you on the show.
Thanks for having me. Absolutely pumped to be here.
Hell yeah. Dude, what has been the worst CrossFit workout you've ever done? What was the most miserable you ever felt afterwards? I know CrossFit, I'll never forget hearing your teeth echo off the bar in Hendersonville. But since that wonderful introduction, what has been simply the most painful experience you've ever encountered?
I mean, when you were mid-question, my brain went right to that workout.
Yeah.
Because, I mean, despite the tooth chip and the concussion, I'm sure.
Yeah.
It was a partner WOD. I mean, with the ICE faculty.
And you were early in the community.
Was not in the community.
Right.
I was I thought I was fit. Globo gym, walking around, do my 3 sets of 10.
Yep.
Partner WOD. Mitch Babcock's my partner, which sounds really cool, but it isn't when you're competing with guys like Zach Morgan, yep. Joe. So we set a pace that was unsustainable for me. So I remember that workout, which probably only lasted 15, 20 minutes, but a good 15 or 20 minutes trying not to void my bladder, to puke.
Yeah.
So my brain goes there.
Yep.
I'm really not a puker for workouts. I puked once.
Okay.
It was actually the first open I did, and it was the dumbbell snatches and burpee box jump over ladder.
Yes.
It had a time cap, I think, of 15 or 20 minutes.
That was bad.
And I finished with 1 second to spare. I was in Ocala, Florida, teaching a course. Finished with a second to spare.
Did you teach all day and then do it?
Yeah.
That's the worst.
Dropped into a random gym.
Yep.
Just random guy who didn't have a partner was judging me.
And let her rip.
Just finished with 1 second to spare, ran outside and puked in the northern Florida climate.
Probably humid as hell during the workout.
I think that was part of it. I mean, in hindsight.
Yeah.
Yeah.
I did that one in Baton Rouge, similar problem.
Oof.
And I did it with Kelsey Kramer, significantly asymmetrical level of fitness. It just buried me. I remember that was a miserable workout.
Yeah, I'd like to try it again, to be honest, because
Yeah.
that was my first year of CrossFit. But yeah, those are the two that pop in my brain.
Were there any teeth ramifications? I'll never forget the hollow sound of that barbell encountering the lower side of your jaw. And just turning it. Did you ever have to get any dental work, or did you shake it off?
No actual work.
Yeah.
But my front tooth is chipped.
There's a morphology
And
that's stuck
it
to
might have been a fork at one point, but man, yeah. The tooth, the jaw, like I could
And
feel
then
it
a miserable
echoing
workout.
in my skull. Like I think that was a concussion.
And I think that was your first ICE physio group workout too. So
Right,
not only
yeah.
were you new to CrossFit,
Exactly.
so there was really no stop. I mean, you needed to proceed.
Wife and I joined CrossFit the next Monday.
Yes. Fantastic. Dude, let's jump into it. And what I want to chat about and just really dive straight into, because there's so many ways we can go with you from the dry needling world. But I think what I get the most questions from personally is, Jeff, what is different about the ICE Physio dry needling courses? And I think that it's a longer answer than they want, but the quickest answer is the utilization and incorporation of e-stim makes it a much different tool. You're going to find a lot more application. You're going to find a lot more versatility. And a lot of them want to know exactly, what do you mean by that? Like, what patients can I now see or serve that I maybe couldn't have in the traditional trigger point method, or maybe a single point stim? I guess, can you just talk high level there, and then we'll dive into some specific presentations. But from an applicability standpoint, How is using e-stim the way that we use it and teach it different?
Yeah, and I think you have to start high level, because I think people talk to someone who took a course, see the social media, and just say like, oh, you guys are doing more e-stim. So like, why? And it's like, you can't really say we're doing it this way because until you unpack the newer research, the whole contemporary rationale. You can say that for any camp, honestly. It's like, why does the piston camp piston? Because there's a whole foundational theory on why myofascial pain exists, why tissue breakdown exists, and why there's benefit to a twitch response. Yeah. The IMS, the gun IMS camp, they don't just say multifidus is important, and they needle multifidus for almost anything peripherally until you unpack the whole foundational model of why that's important. Yeah. So, I mean, we start there too. And I think that's one of the biggest paradigm shifts. And I think a lot of the other educators are going there as well, because it's shared research and it's shared sample sizes of, we started doing it this way in the 80s and 90s. Now we're in the 2020s. I think that comes with a big paradigm shift, not just in how we use a needle. Like if you put the video on mute from when I was needling in 2010 to now, it looks different. But I think the biggest difference is how I explain it to a patient, how we unpack it on a course, how we appreciate it as far as the therapeutic mechanisms. So yeah, I think you really have to start big picture and say this nervous system influence from a needle, which is really where the spine squad goes with not needling, but manipulations and like joint mechanoreception input and all of that kind of stuff. That's now what we're doing with the needle, not necessarily just local tissue changes, sarcomere length, all of that stuff. So it starts there. And then once you have that foundation of kind of the dry needling 2.0, the questions of like, how do we do this best? How do we put out the fire for pain modulation best? How do we improve recruitment the most? How do we generate pressure oscillations to move fluid? And that's where e-stim at this point is almost always a part of that equation.
So let's pause there. And if you would, let's talk about how you do explain that to the patient. Because I mean, there's got to be times, it's funny, dry needling was kind of getting really popular as I was stepping away from clinic after, 12 years, and it was really starting to blow up and never got to use how we do it in the clinic a lot. So I've never had reps explaining when a patient says, this is a pretty complex looking machine. There's tons of leads coming out of it. We're running these huge circuits. Like when they say, number one, what is this doing? And number two, why are we doing it this way? This is not what I sort of expected when I thought about a needle going into a muscle. What is kind of, I don't want to say your elevator pitch, but I mean, how do you go about laying that foundation for their understanding?
I mean, it always has to be attached to the goal, to the treatment goal, the session goal, but to the patient's goal. And it always comes for me after the evaluation, which I mean, it gets tough. I've been cash pay for so long, and people just come in and say, I have my normal PT, I do my exercise, I'm here you do the needling. Like, let's lay on the table and start with the needling. Yeah. And I first have to, let's take a look. Because my spiel, so to speak, is, you know what, Gladys, just had a look. Here's what I think's going on. Yeah. My goal today would be to bring that 9 out of 10 pain down to like a 6 or a 7. One of the most powerful tools I have, it's called dry needling, and this is how it's going to go. We're going to put some needles in. There's a little achy, crampy soreness, but then once we get the stim going, the muscle pumps. All the research, all the data, all the people that come to me is for this treatment, and I think it's worth a try. So I dangle the carrot there. I don't go deep into like the internal pharmacy pain modulating drip and why a needle in this clinical trial did better than manipulation or that sort of thing. I just say, you're coming to me for this. This is what I'm seeing. I think it's worth a try. This is how it's going to go. Are you on board with that? Yeah. And I mean, patients are more data seeking in my experience than I initially thought. Meaning when Gladys is sitting there and her muscles are pumping and she's feeling okay, she's like, so what exactly is going on here? And I'm like, glad you asked, Gladys.
Yeah. Buckle up, Gladys.
Yeah. There's lots of great reasons why you feel better. There is great benefit to just the nourishing muscle pump, blood flow. Like we had some kind of accumulated biochemicals near an irritated nerve. We can pump those out, get you feeling better pretty quickly. Yeah. Muscles function based on neuroelectricity. Like we're kind of speaking the muscles language right now, control alt delete. So I let them ask me the opening the door, like gateway questions that get me deeper.
I love that. And so as you mentioned with Gladys, you identified it was a pain problem. And I think this is where e-stim gets really interesting in that I think at least my exposure, the early dry needling days, it was about myofascial pain. And that was the one thing that you were targeting. Can you speak a bit more now to, as we've adopted a more modern technique of needling, the different buckets? Yes, you can reduce pain and. Can you speak a bit to those ands?
Yeah, dude. I remember the first course, like I was participant, took my first needling course 2010. And I mean, the indications, contraindications was basically you would use it for somatic referred pain, myofascial pain. You might not use it for basically anything else. And it's crazy to think that like even bony articular breakdown, like pain of other tissue origin, obviously anything more complex or neuro. So it's different now. And again, it's the research that's really caught up. And to some degree, research that says, you know what, there's no reason not to try this. Like when you take down the fear, when I was first trained, is like, yeah, we wouldn't want to try it on this. We don't know what's going to happen. But we don't want to try it here just in case something crazy happens. At least now, and why research has really flourished in the past 10 to 15 years is the other medical options are not better. There's no risk to trying it. Let's try it.
Yeah.
And then we're seeing positive stuff with spasticity. We're seeing arthritis change, like a bony intra-articular breakdown that you think a needle in a muscle wouldn't change. Yep. And again, both on the clinical side saying it helped this condition, this condition, this condition, but now we have functional MRI of the cortex. Like now we have some visuals and answers to like, I put a needle in your gastroc, but what just happened at the dorsal horn? What just happened to somatosensory cortex? And that's part of why we've drifted away from this like monocular, microscopic, like sarcomere level view of what needling does. And when you put that layer on it, again, we circle back to like, it's worth trying for almost anything, like not just pain. It's like in the realm I live in, we do it for recovery, not just an injury. We do it for an acute injury, for chronic stuff. Like it's not my realm, but people are using it for neuropopulations. So I think that is the biggest shift.
Yeah. Recovery, I think especially is going to surprise a lot of listeners. By the way, I love that discussion because like you said, manipulation saw the exact same trend line. It was, we do it in these few people because we know it's safe and we know it works. And then it really began to broaden. And all of a sudden you saw research, cervical manipulation for shoulder pain, right? Lumbar for turning on the quad. And you had all these other applications that got more and more exciting. All that had to happen was the fear had to go away. And then all of a sudden the applicability went way up. So it's so cool to see the same kind of trend line going on. Can you speak to recovery specifically? I don't think most people, when they're thinking about getting or delivering dry needling, are thinking about using it for recovery. Can you talk to that a bit?
Totally. I mean, this is the realm that I've lived in. Without going through my whole story, like did the outpatient ortho high volume thing, had a cash pay thing for needling where we still saw kind of lots of different stuff and we use needling for it. Probably 7 years ago, a pretty strong pivot to where I'm almost only treating pro athletes at this point.
Yep.
And I mean, pro athletes, almost all of them have chronic stuff going on and they're dealing with more acute injuries. But sure. I also have a list of clientele, NFL guys, where in season, I'll fly out, show up, and it's like, yep, feeling pretty good, boss. Like no new injury, like just pure recovery mode. And it's amazing to, again, use this modality for something that previously is like, that wasn't even the list of our, not even a contraindication because no one was even saying like, how would we, can we?
Yeah.
And again, I have my patient friendly, like, all right, bro, like we're just going to get your big dumb muscles to pump. Like that's how we move fluid. That's how we clear some of the, the blood lactate, the biochemicals. Like that's how we're going to help you recovery, venous return type stuff. But what's really cool, and again, this is the hook for patients, is there's a massive nervous system response to the needle.
Yeah.
And I mean, out of course, we say vasodilation, vasomotor changes, like the big words. But my NFL guys say, I do the Mark Pro. I get my muscles to pump other ways. Am I doing the same thing? And to some degree, I say, yeah, it's good to pump muscles to move fluid for sure. Yep. There's something unique to the needle. And the uniqueness is the profoundness of the nervous system stuff that we know of now.
Dude, it's hacking the game. It's almost like BFR, right? Where you can load something and get a growth hormone response and a stimulus without actually putting a lot of weight on the bar or the dumbbell or what have you. Very similar that we know that movement is wonderful for recovery, but what a cool thing to almost be able to mimic it in maybe even a more profound way without the person having to do anything. Because I'm assuming they're just kind of laying there simmering on these needles. Is that the case in most of these recovery scenarios? They're just chilling out for 20, 30 minutes and things are just pumping away?
For sure.
Yeah.
I mean, there's guys legit AirPods in,
Totally.
you know, watching film maybe, or just watching Netflix. I mean, yeah. If the goal of that session is recovery, you do all your recovery stuff. I mean, you dim the lights, you aromatherapy,
Totally.
you like, that's the goal, and that's kind of how it feels for that session.
I love that. Paul, what about performance? One thing that's always, I've heard this spoken to, we've dabbled in the discussion. I've never personally tried it and then tried to go out and run a really fast 5K or do anything. I've always felt like, man, the needling gives you some level of post-treatment soreness. Could it possibly increase your ability to execute physical tasks right after? How is it utilized when the goal is to elevate someone's performance, or is that a realistic endeavor in many cases?
It's realistic, and it works, and there's actually data. I'm not going to say like big volumes of research data to say like we do it immediately before a competition, we improve, but there's breadcrumbs. I mean, we do the thing, we test isometric, isokinetic output, and it changes. Some studies take it as far as translating to like vertical jump and squat performance, like a more functional movement. But I mean, honestly, if we're talking recovery or performance, the biggest indicator that it works is that NFL players, and I say NFL players because I see them, but athletes at the highest level have seen value in it for decades. And I know some people that want the highest top tier systematic review to tilt them into like, okay, I guess this works and we should do it. But these are athletes paying thousands to hundreds of thousands of dollars for anything that makes them recover better, be injured less, be on the field more, and perform better.
Yeah, and they've tried all the other shit. They have the resources.
Exactly. You know? Like I don't get a lot of, I don't have Google reviews, but I don't need them. It's like if they're paying me thousands of dollars to fly out and do the thing, they see value in it.
Yeah. Dude, that's fascinating. And the reality is most people, we like to think that we're a bit more data driven than we are. But for most people too, knowing that professional athletes are seeking this treatment is a pretty strong case to give it a shot. If it's not dangerous, it's certainly worth it.
For sure. I mean, if you want the biggest indicator that it works, it's having an athlete or multiple athletes that did it once and want to do it again.
This is my thing.
Yeah.
From a patient perspective, I think that's a great discussion of, we all know it works great for pain, but it also works for recovery. It also works for performance. And some of these I think are pretty unique to the e-stim space. Is that fair? I mean, recovery, you're not going to sit there and traumatize someone's tissue for 20 minutes and get a ton of recovery.
Yeah.
I wouldn't think.
No. And I mean, you had asked me earlier of like, are there things, or what are some specific things that like, if you were trained with the, I'll say trigger point model, but if your main needle application is mechanical input, and I mean, I kind of put twisting and pistoning in that same camp there. Can you do it for recovery? And I mean, it's a hard sell. It's a leap for me, even with previous training, to be like, I know that twitch response indicates sarcomere lengthening, blood flow changes, like dissipation of accumulated, like bad stuff in tissue goes away. It's a really hard sell for an athlete to say, this is good for you, especially in the NFL microcycle of like, you're going to be sore for a day or two, but you just got to believe me that you're going to feel better. And I don't think it fits that realm. And maybe that's why that first course I took, there was no talk of anything aside from pain. It was at the highest level, I think generating that skeletal muscle pump and the nervous system response that comes along with it from needling. Fits really well. Fits really well with the other science, the other things they're doing for recovery. And I mean, moving fluid, you can apply that to interstitial edema of an ankle sprain, lymphedema, lymphatic activation. So, I mean, it unlocks lots of doors when you add e-stim.
For sure. And I think to me, the biggest door for the patient is the one that we just sort of touched on, in that back in the day, the narrative was, we're going to, you wouldn't say this, but I mean, we're going to do a lot of tissue trauma. And you're going to be really sore for a day or two. Like, you're going to get up and your calves are going to be, you're going to have a very hard time walking.
I was so good at explaining to Gladys. It was like, I understand what's going on. it's going to be a pretty rough 24 hours.
How drastically has that narrative changed with the application of e-stim? Are you even saying there's going to be post-treatment soreness, or are you in most cases expecting, because there's so little tissue trauma, that there very well might be none, or heaven forbid, they might even feel better?
Yeah, I mean, if we're in recovery mode, I'm at the point where there's no discussion of post-needle soreness. I mean, that's a pretty benign. You float the needle in,
You're
e-stim
going to get
does
those
the
in
work.
place, and it's going to pump.
I mean, it's the research says it. The patients don't complain about soreness. Yep. And honestly, it's teaching needling for this long, and even seeing groups of clinicians get needled themselves for 2 days and 3 days straight. Yeah. We used to kind of have to have them like buckle up and say, we're going to practice our pistoning. Like, this is good lab practice for you to refine your technique to take back. But there were groups tapping out on our needling courses. So, I mean, the biggest sample size I've seen in the last decade is 10 to 20 clinicians every weekend not have soreness after just hitting 30 muscles.
And you're needling all day.
Exactly.
Yeah.
And I sometimes sometimes I like when that person has experienced the old school one, because I'm like, yeah, bro, do you remember your course? Because it's like, this is a lot different. And I think the newer generation that maybe didn't experience that previous model, and they dive right in with pistoning a little less, doing more e-stim. To some degree, I get questions or eyes. I'm like, what are you talking about soreness? Like, I'm not sore. Like, will it always be sore? And the answer is no. It's like the dosage spectrum is, we've unlocked doors, but we've really refined it to be like, man, we can really apply this sharp, pokey object that we used to immediately apologize about how sore you're going to be. We can apply it relatively comfortably. And even if there is some slight temporary crampy discomfort with the needles in, there's no soreness afterwards. So I think we've gotten better with the needle dosage and also what to do after the needle.
I want to get back to that in 1 second. In clinical practice, for your broad swath of orthopedic populace who's listening to this, what do you recommend when training the way that we're talking about training people, when that patient says, I'd rather not with dry needling? I did that a few years ago. I could not walk for a couple days. How confident are you, or what do you recommend for a narrative? Are you going to tell that patient, look, I'm telling you right now, you're not going to feel a damn thing tomorrow? Where are you going with that at this point?
I mean, it has to be a conversation, right?
Yeah,
I mean, if a patient walked in and said, oh, you do manual therapy, I've had manual therapy, I loved it or I hated it, we have a lot more questions. I'm like, well, was it a quick snap? Was it sitting there like pushing hard on a joint? Was it soft tissue? Good news, bad news, dry needling is the same. I mean, if someone comes in, they're like, yeah, I had needling, loved it or hated it, I have more questions to ask. I'm like, cool. How many needles was it? Were they moving the needle around? Did they use e-stim? What did they do afterwards? Because at the pitch for people that go through our courses, and really, I look at myself in the mirror, like how I used to do it and explain it and how I do now, is I just tell Gladys, and maybe she is like, yeah, I don't love needles. Tell me more about it. Or if you're saying this is the most effective, I'll consider it. I'm very confident right now saying what we're going to do today is going to be very different than what you just described to me last time. Yep. That soreness you experienced, it doesn't have to be that way. And part of it is how we're going to use the needles. We're going to do some e-stim. Part of it is what we're going to do right after. Very confident in that. Cool. And I mean, I don't know if it's my sample size or just the e-stim is that powerful that a novice clinician will have the exact same results, but very confident saying, if you had needling like this before, this is going to be a lot different.
I love that. Go ahead and discuss what you do after. You've alluded to it a couple of times, but clearly there's two halves to this. There's the fact that needling is done very differently, and that's advantageous, but we've also learned a lot about what to do once they're up from the table. Speak to how that affects it.
I mean, it's easy. It's movement. I mean, and again, I remember the one pager they gave us after my first course in 2010, and it was rest, ice, heat, kind of take it easy. You're going to be sore, like don't overdo it kind of a thing. And I think there was even caution to like gastroc soleus, those fast twitch muscles where you might have a big change in range of motion. There's almost like this caution of like, don't send high force and load, like don't have them run or box jump. And again, it was an ultra conservative fear-based, like we just don't know what's going to happen. Now it's the opposite. And I mean, research telling us this group got their ice or heat thermal modality. This group just went out and did some concentric, eccentric TheraBand after hitting infraspinatus with needles.
Yep.
And I throw this in courses a lot. And I'm like, which group do you think had less soreness? And everyone, when I frame it like that, it's like, oh, it's the movement group for sure.
Yeah.
So, I mean, in the context of we want this patient to tolerate it well, to come back and try it again, but also in like the needling being such a powerful tool for short-term stuff. Like, how do we make it stick? It's always what you do after. Like on most courses, within the first 30 minutes, I'm like, I don't care if it's your first needling course, your 10th needling course, 90% of your outcomes are based on your evaluation. Are you targeting the right stuff? And what you do immediately after. And immediately is like in that session. And then what you tell a patient to do 24 hours later.
I love that because, too, it takes a little bit of that sort of external locus of control problem away. If the patient feels like, yes, that was part of why I got better, but so was the part that I did. Like, nice to have that combo in the same way with manual therapy and exercise.
Yeah, exactly.
Okay, so we've got already high level that just the mechanism itself is a bit more advantageous. We've added on buckets like recovery, like performance, in addition to pain, because of the way that modern needling looks now compared to how it used to. Are there any specific diagnoses or clinical patterns or conditions that you're like, Jeff, 10 years ago, or my first course in 2010, 2012, that era, I was not or could not have managed this presentation all that effectively with needles, where now I think we crush it because of the way needling has evolved? Do a couple of those jump out at you that maybe clinicians can listen to and be like, oh, I've never thought to use it on those folks, or oh, I would love another tool for those folks? Any conditions like that?
For sure. And I still think of buckets, so I'll try and think of specific diagnoses, because my first response wants to be acute injuries. And I mean, let's say
ankle sprains,
or even the acute low back, the acute neck. I mean, it's, again, a hard narrative, a hard sell to say going in there mechanically disrupting this is going to help even your pain at that point.
When you're flared up and freaked out.
This muscle, this disc, this nerve is irritated. Like, this is good. This is going to be good for you. And I mean, anybody who's trained that way knows, is like, yeah, if they're honest with themselves, like, yeah, when you see that lateral shift, like that disc, like walk hot stuff through the doors, like, you're not going to be like, all right, Gladys. It's like, we're going to piston some needles in your paraspinals and that sort of stuff. So I think, and I mean, depending on who you treat, those people will try anything. Like previously, I would never think of doing a needle. Do whatever you want, because if this session doesn't hit, I'm going to the ER or urgent care. Like, this is severe stuff.
And so to frame that for the clinician or patient who might be listening, I mean, we're talking about that person who walks in and they are locked up. I mean, they are either not wanting to turn their head and neck, not wanting to turn their low back, can't flex forward. They look kind of semi-paralyzed in a way, tons of fear, tons of protective mechanism. Very recently said, I picked up that bag of pot soil, or I did this deadlift, dude, something happened in my back or neck. And they're now seeing you inside of maybe 48 hours. And like you said, they're really considering one of a few things. I heard that you can help. If you can't, it's a Metaral dose pack, or it's an injection, or it's some imaging. But they are right at that spot.
Yeah, and it works. I mean, for previously being afraid to do it, or it not being appropriate, which I think is accurate, it helps. And I mean, the whole narrative is like, again, the science says you're not, or I'm pretty sure that the way we apply the needle today is not going to make you more sore. It's definitely not going to make your pain get worse. And I go into some education of like, if we can generate that tiny little muscle pump close to ground zero, and if ground zero is that annular tear, that irritated disc, whatever, like we can get to the deepest muscles there. And if there is a inflammatory bath near that injured, during that nerve root, sensitizing it, the best thing we can do right now is getting blood flow going very locally with the needles. But then the rest of the plan is, can we get you walking, on a bike, moving? It's like anything we can do, blood flow, muscle pump, heart rate wise, like when we can start getting to that stuff, all of the data we have is that this is either going to be a month thing versus a 2-month thing, or the opposite. But it plays really well. I mean, it's tough to get Gladys comfortable prone on the table sometimes, but once you do.
Are we rocking sideline with Gladys a lot? And just
that's
just
the play for that person. Otherwise you have 17 pillows, a hot pack, you're tractioning.
For sure.
But it works. And I mean, that's a specific diagnosis that wouldn't work in the past.
And what's exciting about that one is there's not a lot else that does work. And I've manipulated plenty of those people, and it does move them slightly in the right direction, but not quite to the level that I'm hearing from you all that letting them simmer on a proper needle setup does, where they get up and they're like, dude, I'm not 100%, but I am significantly more able to move.
For sure. I mean, that goal, that human and us on that day have one goal, and it's not 10 out of 10 gets to 5. It's like standing upright and like 10 becoming 8 and finding 2 movements you can do for the next 24 hours till you come back and see me again. And again, you're still doing all your other stuff, but man, it works.
Dude, that's the part that people need to reframe some of this. I'm going to put all of this under body work, needling, cupping, manips. Everybody's so focused on this narrative of it only does a moderate amount for a small period of time. And that is it just shows me someone who hasn't been struggling in practice for long enough, because doing a moderate amount that makes the patient look at you and say, hey, maybe I'm going to be okay. Again, I am not all the way better, but that was noticeably different. And someone who says, I am going to go for that walk tonight, just a walk, but I'm going to go move a little bit. Dude, those are the wins that temporary changes in pain give, that are so much more profound than the intervention itself. And we don't think about that enough.
For sure. I mean, you make it sound way more, way easier. There's deep pain science there, and there's clinical skill. And honestly, for someone in that level of pain, for needling, I don't think it's like you are so much more skilled with the needle. It is communicating to that human that this is not going to make it worse. In fact, this is one of the best tools to make it better in the next hour, 24 hours. And when you have the tone, the confidence, I've done this a million times before. When they perceive, they can tell, I can tell how the level of pain that you're in right now.
Yeah.
I want to do everything in this session to make that better. It's going to start with this.
Yep.
I mean,
dude, it's a trajectory shifter. It's you pulling that off and the patient believing in you enough that you can get that intervention done, and they can say, hey, I feel like maybe I'm on the right path. It's unbelievable. For those who haven't been in clinic for a long time, they don't realize the power of someone thinking, I'm screwed, versus I feel like maybe I've taken the first step in the right direction. That's what breaks that cycle. That's what changes someone's psychology. That this is what then opens up other doors. But it is that trajectory shift, and something like a 10 to a 7 can do that.
For sure. I mean, I'm a number-based person. I'm kind of analytical in that way. I mean, communicating that to patients is helpful, I think. Yeah. I mean, sometimes Gladys just wants hope and just I think this will work. But yeah, having specific goals, and I mean, I'll try not to tangent too. I love the pain science tangent. Honestly, when people tell me I've taken 2, 4, 10 needling courses, what outside of needling would level up my needling the most? I'm like, it's pain science. I mean, it's having that Justin Dunaway intellect, and having, again, that be able to connect the dots between, again, a sharp object, which they perceive as potentially very uncomfortable. And I mean, maybe even making their condition worse if you're talking about putting a needle pretty close to ground zero, but having the ways to communicate it and confidently. I mean, that's the people I've really looked up to in my career are just expert communicators. And I mean, I think the needle skill acquisition comes really quick. And again, I think e-stim gives you a real easy way to do it without having that other end of the spectrum.
Yeah, I love that. Paul, can you give us one more? Do you have one more? So really hot mechanical spine pain is such an amazing example, because that person's in such a bad place, and there's so few other interventions that really budget. So to have something that you can confidently look at the person and say, this is going to move you a bit in the right direction is massive. Do you have any others that you could see clinicians saying, oh gosh, I really, I haven't used needling for that, maybe because I don't understand some of these new ways of going about it?
Yeah, and I think we've mentioned some, and they're kind of the buckets of if we're saying we can generate this muscle pump, which does some local and some nervous system type things, it is that lateral ankle sprain, where previously we wouldn't touch it with a needle. It is lymphedema. It is, and from there, the other silo is all the advanced techniques we do now. We can approach a peripheral nerve with e-stim. We would never piston it. We would never directly contact a nerve over and over. Same applies for scar techniques. I mean, Ellie Melrose, one of our leads, she primarily sees pelvic postpartum. So you're saying C-section scars, and that can be pain, that can be actual tissue health and aesthetics. Like, there's lots of things.
Do you mind speaking to that peripheral nerve one a bit? Because a lot of people, I think when they think needling, the first thing they see as maybe a red flag outside of the lung is a nerve issue, let alone the idea of therapeutically managing what again can be a super, when someone has legitimate like peripheral nerve pain and any level of sensitization, like where the pain is, how broad the map is, the nature of the pain is so awful, almost like toothache-ish, but worse, you know? Can you talk about how needling can be therapeutic for that kind of a peripheral nerve lesion perhaps?
Yeah. And I mean, we tackle it on our advanced course, and I kind of love seeing the eyeballs of the groups of like, yeah, we're going to stim some nerves this weekend. Cause I mean, these are groups of people like taking the course that had just spent months, years of their career trying to avoid a nerve. Right. And now you're like, did he just say we're going to do a peripheral nerve stim? What surprised even me is that the research is way more supportive. In fact, it's better than some of the frontline surgeries, injections, and meds for true nerve injuries. Like the nerve was severed in surgery. There's a true nerve palsy. Like when the peripheral nerve is compromised, they compare it to TENS versus PENS percutaneous. It stands up really well. And there's other ways to improve it, but the research is supportive, not just for that nerve injury, for pain. That's kind of a tangent that we won't go into, but there's data that says putting e-stim on the sciatic nerve changes back pain, changes low back function, being flexion and some of the functional scales, quality of sleep, all that stuff. So it's fascinating. And I mean, we present on the advanced course kind of like, here are a few missing links. Here it's still kind of some core curriculum stuff. Then we kind of just open the gate and say, this is where needling is going. And I put peripheral nerve stim in that category. I mean, immediately the hands come up and they're like, so are we doing this for all patients for pain or for all patients with nerve injuries? And I'm like, maybe not a first visit thing. I mean, you have to, back to what we just talked about, you have to establish the rapport, the expectations. This is what the e-stim normally feels like. Today, I think it's worth taking that e-stim closer to a nerve. It's going to feel different, look different, but all the data I have say, because the nerve is most irritated or directly injured here, it's worth it. And I mean, that's where we're at. I mean, neuromodulation is huge in the pelvic crowd, not just for pelvic pain, but pelvic floor function. Yep. And I mean, I again see it as just another option and a highly valuable option for those Gladyses where we have emptied the clinical tank. Totally. Maybe even needling. Like maybe it's like, oh man, I really was hoping this was going to work. We kind of improved, then we didn't. Now we're sitting here saying, are we better or not? There's one more thing we can try before you go back to the specialist. And we all know that road is imaging, medication, surgery. So having one more thing is sometimes the thing that we need.
I love that. I got to ask you one more thing, because I know a lot of listeners are out there who maybe don't have this toolkit or tool set yet. And they're thinking, that sounds great, Jeff and Paul. I'd love to have all those other buckets. I'd love to have recovery and performance on top of pain. I'd love to have less post-treatment soreness. I'd love to be able to manage acute pain and peripheral nerve issues. And I'm sure I would be able to eventually. And what I mean by that is, I'll never forget a lot of the gatekeeping and early manipulation therapy. It was like you couldn't do thrust until you've taken 97 courses that got you there. And even then, it was a 7-course series of which you didn't really expect to get most of the benefits out of thrust manipulation until the very end of it when you were truly a Jedi Master. You've trained so many clinicians. How do you feel regarding if someone's sitting there saying that and they jump into our upper extremity course next week or the following? How much is the actual psychomotor skill and reps limiting their ability to maximize all the benefits we talked about on this episode? Or do you see that with the ES160 and the way that it's done nowadays, they're getting a pretty decent percentage of what they're going to get 10 years from now?
Yeah, we build it in right out of the gate. It's part of our Dryling 2.0 playbook is the e-stim strategies. Yeah. So, I mean, what's been fascinating to see, I mean, we've been ice dry needling around for 3 years, kind of the new kid on the block. Straw pull, it's about 40 to 50% showing up to our courses saying, I know how to put the needles in. I was trained here. Yeah. I'm just here for the e-stim. And that piece is easy. So, I mean, whether you're showing up saying, I've never held a needle, we master the basics. Basics are important when you have a sharp object in your hand, but upper and lower, we do e-stim. And I mean, primarily those 3 e-stim strategies being, okay, our goal for this patient, these needles this session, is to change pain. Talk about the science, how to dial it up, like what's the optimal dose of e-stim. Mm-hmm. This patient, pain is a little bit less of a concern. We want to improve muscle responsiveness, combat atrophy, improve output. We can dial it up a little differently versus recovery mode or moving fluid is like, maybe we connect different dots, like put needles in different things. Maybe that e-stim layer is more important there. But we do it right out of the gate. I mean, the nerve stim and stuff is advanced, but I'd say if you're trying to use your needling for some of the blind spots and gaps we mentioned, I mean, our first course, upper and lower.
Okay, so if a student said to you, and they were a good student, they memorized all the settings, they understood the e-stim machine, they knew all the circuits, their diagnostics were solid, would you say to them, hey, with all of that knowledge and your very rudimentary psychomotor dry needling, so let's say they've never needled anybody ever, would you say to them, and I know you can't give me an exact number, but try, hey, you're gonna get next week in the clinic, you're gonna get 50% of what you're ultimately going to get 10 years from now when you're really buttery with the needles and your psychomotor is amazing. You're going to get the other 50%. Or would you say the psychomotor is really not, as long as you can get the needle in there, the other stuff is so powerful, you're going to get 80%. Yes, you'll get a little better with your psychomotor proficiency increases, but you're going to get the vast majority of clinical value right away the following week. Where do you sit on that spectrum?
Like you want me to set percentages?
Yeah, how I do. I want a gut shot on when someone's new to the psychomotor, how much does that limit them from exhausting the benefits of needling in the clinic? How long do they have to wait to be able to get all of it out of the tank?
Man.
Yep. I'll never hold you to this.
No, and I'll think of a number once I paint the picture. Because I mean, I picture that person never been on a needling course.
Never needled.
Meaning you're fumbling to take the shim out. Like
patients in front of you, it's a little clumsy.
It feels weird to have gloves on. Like you don't know exactly how to set the guide tube. That skill acquisition by the next day is gone. Okay. I mean, so now you're saying, okay, I know the basics of how to like tap a needle in, how much of like skin interaction down to like where I'm actually trying to go. Yeah. I'd say by the end of the weekend, 30 to 40% there.
Okay.
And I mean, there's states where it's like you can take that and start using it in the clinic right away.
Sure.
And obviously getting reps right away. Like if you don't use it right away, you kind of lose some of that skill.
Yep.
I think you can get to 60 to 70% in 3 months.
Okay. In that other 30% where you truly have mastery of that sense of tissue and exactly where that's going to come over the next few years.
Yeah, I think so. Because I mean, e-stim to some degree, I'm saying covers your bases. Maybe we don't have to be like as aggressive, and to some degree you can kind of get away with like dosage because they're not going to be as sore.
Yeah.
But with great power comes great responsibility. Meaning, if you do e-stim at all, you know the difference of like, your needle's in glute medius, your needle's in vastus lateralis. No one's going to argue that. You didn't miss the muscle.
Yeah.
But just the expert clinician that turns it up, you know, we tell Gladys, you're going to achy, crampy, sore, it's going to pump, and you go right there. And if you're not right there, you make a tiny little adjustment and you're there. Versus the novice clinician turns it up. Gladys is like, oh, that's a little snappy. So you turn it down, apologize, like repalpate, like do that. Yeah. 30 seconds later, does that feel better? Like, yeah, maybe yes, maybe no.
Yeah.
The precision and how to make those quick fine-tuning, confident adjustments, I think that's that last 30%.
Totally. Well, hey, that's a pretty exciting number because I'll be totally transparent. With manual therapy, which I taught for a long, long time, the number's lower than that. When someone was brand new to manipulation, and don't get me wrong, it's better than not having the skill, and you got to start somewhere. But there were a lot of times where someone grabbed your neck and you were like, ooh, that's quite a ways away from being therapeutic. Like, you're not getting 60 or 70%. You really do need to get reps. I think manual handling probably comes with a little bit longer. You have to rep this out before you're exhausting the tool. Whereas with the e-stim, it's like you said, as long as you get it in the right muscle, a lot of the other stuff happens over here, and that probably doesn't take quite as many reps.
And I think the e-stim, I mean, when you're first learning, it's very validating of like, I just put a needle in what I think is a rectus femoris. Does that look like a rectus femoris? So I think you auto-correct quickly.
Yes.
Early on, I think some people bail out a little too shallow. Like, no, the muscle just lives a little deeper.
Yep.
I actually find sometimes I overshoot my targets. Like, yep, guess that sweet spot was just like 2 millimeters shallower. So when you start using the e-stim as a final judge, almost as a learning tool, it really sharpens your skills.
That's so huge, because one of the challenges of getting great at manual therapy is you can't feel it. You can't, when you're looking with e-stim on, you can't feel what they're feeling, but you certainly have a visual representation of what's going on.
Yeah.
That's different.
Dude, it was so easy to teach needling when we didn't have e-stim. We're just sitting there like, and that's soleus. Any questions? And like, maybe it twitched, maybe it didn't. Like, but when you put e-stim on and like, well, that doesn't look like a soleus, sir. It's like, you really need to prove it with your e-stim. Like,
yes.
I love having our new TAs faculty. Like when you go through the audit, you have a lead over your shoulder.
Yeah.
And it's like, you're going to do e-stim on every needle because I want you to prove that you're on the target that you are. And I mean, that's the skill. But I mean, that early stuff, Regis, I had Tim Flynn. I mean, I remember the advanced manip elective. And I mean, he starts somewhere in the morning with like, you can teach a monkey how to manip. Like the higher skill is like knowing when and how and all that kind of stuff. Yeah. That's kind of how I feel about a needle. Like no matter where you're at, I think by lunch, I feel pretty confident you can tap a needle into a muscle and we can go from there. So I think, if there's a fear or like a thought that like, I wouldn't want to dive into needling because, man, that's a new skill that's going to take years and years to refine. I don't really think it's that way. In fact, I think you see pretty quick success. I think even sometimes bad needlers get pretty decent results. And I mean, maybe they're just really slick with everything else they do, but...
Yeah. Very cool. Very encouraging. And speaking of getting those skills, Paul, there's so many more things I want to talk to you about, but we have other episodes to have you on and dive deep into legislation and so many cool things going on in the dry needling space. Until then, we've mentioned advanced, you mentioned pelvic. Can you just tell the listeners how exactly our dry needling curriculum and courses are designed? Maybe, what you would get out of each one. Just a really high level discussion about that if they're looking to get trained.
For sure. You can enter our path, I guess, in upper or lower. And then if you're going to advanced, we actually just require you take one of those to get to advanced. And really our goal is that on upper, we give you 90% of what you need. It's not like we're trying to hook you and like, oh, you got to come back for the other half. Yep. And same with lower. And I think depending on your clientele, I mean, we even have other professions like occupational therapists or athletic trainers that just want half. So it really is our goal. We do not like level 1, level 2 muscles. I mean, if we're lower, we're doing TL junction to the foot. If we're doing upper, we're doing occiput, T-spine all the way to the hand, plus layering in that playbook for e-stim. So, I mean, lower, it's like you learn kind of the anatomical building blocks. You layer in kind of that e-stim recipe, but we immediately start talking back pain, hip pain, knee pain, Achilles tendinopathy, cervical headaches, cervical radiculopathy, shoulder pain, elbow pain. So, I mean, our sample size of teaching this for decades is like, we used to just show up on our first course and be like, we have one goal, like to teach you how to safely use a needle. And I think at this point, just knowing where the standard of education is, having more safety data, having a larger sample size of people taking courses, safety is pretty easy with the needle. I mean, only always be safe. Don't think I'm minimizing safety, but we really don't just want safety, but like how to use this pretty precise tool pretty specifically, and then how to be strategic with it. I mean, we really hope if you can use it with your humans on Monday that there's a direct translation into how you work, but like the ROI, it's expensive Con Ed for sure, but most people that eventually buy the ticket, sit in the seat and do the thing, say, why did I wait that long to do that?
I love that. And for those that are concerned about hours or state specifics, because there's plenty of those around dry needling, you can find a 2 or a 3-day course depending upon what you're looking for or what you're required for your state law.
Yep.
And that's true for advanced and for upper and lower, or just for upper and lower?
So upper and lower for sure.
Okay.
Advanced, we're really trying to keep 3 days. Cool. I'll just say that.
I know you don't teach it, but speak a bit to pelvic. They can certainly connect with Ellie more if they want more specifics, but Where does that lie as far as prerequisites? I mean, the content's pretty obvious. We're going to be going after that pelvic floor region, but where does that sit as far as gateways to get into that course?
Just lower body. Okay. And again, there's obviously some important overlap. We do sacral multifidus, deep hip stuff, glutes. So, I mean, adductors. So stuff that will be valuable on the lower body course, but it's really the e-stim playbook that it's tough. I mean, we get the messages of people that want to go straight to advanced or straight to pelvic, and without that e-stim strategy and kind of where we're trying to go with our treatment goal and the e-stim tactics, it's really tough. You'll feel a little out of sorts if you just jump right in. But I mean, as of this recording, the first pelvic course is coming down the pipe.
We're here. We're in Fort Collins.
Yeah.
Here, yeah.
Man, it's going to be huge though. Like if there's one ask I get every weekend, even on upper body courses, like, are you going to do pelvic needling?
Yep.
And I've seen the program. The way Ellie built it out is perfect.
Beautiful.
It's not just a new random list of anatomy. It's treating specific like pelvic postpartum pain syndrome, C-section scars, de Quervain's like mom's wrist. So, I mean, if you see that population, this is the needling course for you.
Fantastic. Awesome. Paul, last question. Where can folks find you? If they have a follow-up question, where's the best spot? How can they connect with you?
So Instagram at DPT with needles, all spelt out. Otherwise, if you're on the app, it's a really cool way to just send a DM.
Awesome. Paul, thank you so much, man.
Of course. Thank you.